Hi, my name is Nicholas Campbell. I'm an internal medicine resident at University of Tennessee College of Medicine here in Chattanooga, Tennessee. And this is our case, but done alongside Jatina Okereke, John Austin Ash, and Maria Tudor, our attending. It's called Where Did That Come From? It's an atypical case of COVID-19 infection. As many people are aware, COVID-19 has a wide range of presentations from asymptomatic to ARDS. This case is a lady who was asymptomatic but found to have a large pleural effusion. So, our lady is an 83-year-old female. She has a history of coronary artery disease, hypertension, atrial fibrillation, generalized anxiety disorder, COVID or COPD on 2 liters, and severe debility. She was transferred from a nursing facility after testing positive for COVID-19 and an isolated episode of hypotension. She was less interactive compared to her baseline, but there was no reports of shortness of breath, chills, fever, or any other symptoms. Her initial vitals were 96, heart rate, respiratory rate was normal, blood pressure was 113/57, and oxygen saturation was 98% on 2 liters. Her physical exam was significant for bilateral rhonchi and decreased right breath sounds, and she was minimally interactive for us. Initial chest x-rays in figure 4, which revealed a large pleural effusion, and her CTA, which is in figure 1, shows patchy ground glass opacities and the large pleural effusion. Her serum labs are shown in figure 2, which reveal normal white count, elevated D-dimer, normal BNP, normal ferritin in a urinalysis consistent with urinary tract infection. A thoracentesis was obtained and 600 milliliters of yellow fluid, shown in figure 5, was obtained and revealed lymphocytic predominance 94% and a protein ratio 0.61, suggestive of an exudative effusion. And you can see the serum labs, or the pleural labs, in figure 3. So, regarding her course, she did not receive treatment for COVID-19 because she didn't have any respiratory symptoms or increased oxygen requirement. The thoracentesis was primarily done for diagnostic purposes. A follow-up x-ray was obtained and shown in figure 6, which showed improved pleural effusion. And she was treated for urinary tract infection, and her mental status modestly improved. She went back to the nursing facility after being with us. Regarding the etiology for pleural effusion, she had a wide differential initially, which included heart failure, pulmonary embolism, pancreatitis, and malignancy. The first 3 were ruled out or removed off the differential based off lab values in her history. Malignancy, given her age, was a concern, and cytology was intended to be sent but never was. She, because of this, we did a detailed literature review and found out that there have been similar cases of COVID-19 with exudative effusions and lymphocytic predominance. Because of this, we felt confident that her pleural effusion was likely due to COVID pneumonia and not malignancy. And she didn't have any other history or features that was concerning for malignancy. And viral pneumonic effusions are, they have been reported before with other viruses. I mentioned COVID-19, and the first 4 references there have reports of COVID-19 pleural effusions, but there have been reports in MERS, SARS, and H7N9. These are usually benign and will resolve with the illness. However, there has been some literature to say that they are independent predictors of increased mortality, and that might be based off specific viral illnesses. So our main point that we're trying to get across here is although rare, COVID-19 has been shown to cause onychia pleural effusion. This can occur in patients without respiratory symptoms. I think what makes our case more rare in compared to the other cases that have been published before is the lack of severity and her being asymptomatic from a COVID-19 perspective. So that's our case. Thank you for listening. I really appreciate it. Below, you can see there's a QR code that has this PowerPoint, or this poster, and has our written abstract. If you have a hard time reaching there, or if you have any questions, feel free to email me. My email's below right there too. Thank you.